There was an opportunity for us as Cochrane Skin to get engaged. We hadn't done any diagnostic test accuracy reviews, and we had the chance of working with the DTA group in Birmingham, John Deeks and Jack Didis. Wow, a chance to work with them, and they actually wanted to work with us because they thought skin cancer was important. Patient benefit, again, you know, I mean, that's the actual main purpose of doing these reviews, is does it actually, is it based on evidence, and can we demote technologies that are just trendy? Money and prestige, well, wasn't a substantial bit of money, but it nearly killed us. And I was thinking back when it all started, it was actually at the colloquium in Quebec. And here is evidence that I did actually go to Quebec. There's my friend, Bob Delaval. We had this strange tumour appearing from our backsides there. And I'm pleased to say it's been excised, and we are quite healthy now. And then I did meet with these people for another discussion, but they were rather stone-faced. That didn't go very far. So how did we do it? Well, I think I'll just run through a dermoscopy example, which was the biggest review, with 659 pages, 109 studies, and I'll just whip through it for you. It's very important in any review to have a clear question. So the points I want to make here: is it dermoscopy alone, or added to visual inspection for a lesion? For the detection, we define the target disorder as invasive melanoma and atypical intraepidermal variants, that's lentigo maligna and melanoma in situ. And we separated them whether they were face-to-face or image-based. Most of them were image-based studies. Huge search, very thorough search, typical of Cochrane. Selection criteria, fairly sort of standard criteria. 2 authors, huge team of reviewers, plastic surgeons, dermatology trainees, and then we assessed quality. The quality assessment tool, it's like a risk of bias, is QuadAS tool. And we had to contact a lot of authors. And just to remind you some of the classical biases in DTA, diagnostic test accuracy studies. Incorporation bias is where your reference or gold standard includes information from your index test. Partial verification bias is where those, I think that's a cancer, they get the histology. Histopathology is the reference test and others don't. Or they're not included in the actual total data. Differential verification means some get one type of reference standard and others get a different reference standard. And imperfect gold standards. Remember histopathology, you only, when you slice up a melanoma specimen, you're only sampling 5% of the total sample with the bread loaf technique. So it's not a perfect reference standard, and just bear that in mind. Analysis, well, the way you put all the studies together is using this receiver operating curve, and you look at the summary receiver operating curve. We look then at, because the studies are very often not combinable, we fix the sensitivity and then look at the specificity, or we fix the specificity and then look at the sensitivity. Now this is very crucial. And it means you have to draw out the clinical pathway, because the spectrum of patients and lesions and what is being done will differ greatly. Whether these are being, the questions differ greatly. Whether you're triaging patients, should they be biopsied, or is this a skin cancer? The questions will differ. And we had to do this review, present it for all of these different steps in the diagnostic pathway, and that was quite complicated. This took a lot of time to produce. So what did we find briefly? Well, don't look at the details, but I mean, you're looking here at 50,000 abstracts and 16,000 full text papers. I mean, a lot of work to end, and this is just one of the reviews. This, you'll be familiar with risk of bias for randomized controlled trials. This is what sort of a summary risk of bias looks like for the QuadAS 2 tool. The ones on the left are within trial or within diagnostic test accuracy studies, and you can see that they're pretty good for describing the actual technology, the index test, and how it was done, and they're pretty good for describing the reference test of histopathology and clinical follow-up, but not the other things. And This, on the right then, deals with applicability, if you like, the external validity of how can we relate this evidence to the sort of patients you may see in clinic and primary care. And universally, these were poor across all reviews. So that's an important point. They were good at describing index and reference test, but applicability was generally poor. And this shows you a summary of the in-person evaluations for dermoscopy added to a visual inspection. And you can see they vary a lot in terms of sensitivity and specificity. And this is the actual receiver operative curve, sensitivity against specificity. And you can see here that there is a clear blue water between visual inspection plus dermoscopy in red. Look at the red triangles, and visual inspection alone. There is a pretty clear separation, and that's probably one of the only clear conclusions that we've had. So some quick bottom lines for the other reviews, looking at visual inspection, lots of studies, standard practice, will miss melanoma if used alone. Dermoscopy should be the standard. In-person is better than images, much better than images. Evidence is generally flawed, poorly repeated. Algorithms, you follow a particular checklist. There's no clear evidence that they work. That doesn't mean they don't work, but there's no clear evidence that they work, and further evaluations needed. Dermoscopy and reflectance confocal. Dermoscopy I've just talked about. Data in primary care, however, where lots of GPs in our country are playing with dermatoscopes. Are they doing a good job, or are they actually confusing? Is it just sort of playing with gizmos? We don't know. There's not enough data in primary care. Reflectance confocal, not much data, but it may be useful. Smartphone apps, very popular. You can download an app right now. Not a lot of data there. We looked at 5 apps and 2 cohorts, but there is a worrying risk, particularly for melanoma, of poor sensitivity. Look, 7 to 73%. Not good enough. It could be good enough in time, but it's not at the moment, so be careful with these apps. Keratinized skin cancer. Dermoscopy may be useful in secondary care, diagnosing BCC in adults, insufficient data and reflectance. Exfoliative cytology, we don't have any information on diagnosis. It's good for confirming a diagnosis when you say, I know this is a BCC, I want to send this patient for radiotherapy. It's pretty good at confirming, but we don't know what the diagnostic accuracy is. And looking at all 3 cancers together, teledermatology, I was surprised the studies are pretty poor. Pretty poor. There is a signal that it's likely to improve triage. No, I'll send this patient to secondary care. No, I don't think you need to worry. There is some evidence that teledermatology may be useful in that triage sense, but it's not very strong. And computer-assisted, where you're using artificial intelligence to analyse, sensitivity looks good so far, but there is still a big gap on translating the evidence into clinical practice, and there are lots of systems out there. It's unclear which is best, and it's unclear whether they are helpful for keratinocyte cancers, particularly in the primary care setting, where perhaps they are likely to be used. High frequency ultrasound, insufficient evidence. OCT, optical coherence tomography, may be useful for difficult to diagnose BCC, but there's insufficient evidence on the rest. What does it all mean? So here are some summary points. There is, you think our randomized controlled trials are bad. Test accuracy studies in skin cancer are also pretty bad. Flawed designs, poor reporting, and particularly in terms of external validity. How can you relate the results to your particular patient? Perhaps the only big message that came out of this is this pretty clear evidence on the value of dermoscopy, particularly face-to-face. The use of algorithms is uncertain, and it's critical. This is a learning point. You have to refer to the population, setting, and clinical pathway. So whenever you look at a diagnostic, think of the diagnostic pathway in your country. It may differ from country to country what happens, but it's critical in a DTA study to think of where in the clinical pathway and what questions being asked of whom. If you were to ask me what my pick of research priorities would be, would be to harmonise pathways and outcomes, relating to the work we were doing yesterday, to develop a common international language, because it's haphazard and random at the moment. We should abide by some basic standards. You know, if you got starred for reporting of diagnostic test accuracy studies that very few dermatology studies pay any attention to. You've got QuadAS2. If you're designing a DTA study, look at those and work with methods, people. You know, epidemiologists who are used to working with Patrick Bossite, for example, in the Netherlands. There are some great people around. And evaluate demoscopy in primary care, and whether the algorithms help or whether they confuse. Maybe teledermatology in primary care. And maybe if you're updating a review, the smartphone apps, because the apps and studies are increasing, that would be a good one to think about updating in 1 or 2 years' time. I keep coming to this sort of model of evidence-based medicine. This is an old Welsh milking stool, and I always like these 3 arms. You know, you've got the evidence, you've got the patient and practitioner, you pull a leg away, the stool falls over. And I think what has happened in the history of dermatologists evaluating diagnostic tests for skin cancer is they've done it in their own little world. They've been given a toy to play, like optical coherence tomography. They play with it and they just report a sort of a series of patients in their own way. And what they report in terms of the use of the test and the reference standard is fine, but they just ignore the rest of the methodology of reducing the potential for bias. They've done it in their own way, and it's essential to consult with patients to ask, well, what questions are of most importance to you? Talk to the dermatologists and general practitioners who are using these tests. What's the most important question to you in what setting? So it's really coupling these dermatologists who are playing with these tests to do some basic good methodology. So what did I learn? Well, I learned utility of a diagnostic test is more important than just looking at sensitivity and specificity. Sensitivity and specificity are important, but they're not everything. So don't look for the best trade-off. Look for utility. Reflectance confocal microscopy, for example. Talking to some experts, thinking, should we do another study? And they were showing me these pictures of these cells. And saying, there's the end of the lentigo malignant melanoma. I couldn't see it at all. It really is. And then as it transpires, you need about 2 to 3 years of training to use it. And the machine costs about £500,000. It's not practical. You have to think of utility. Dermatoscope, you know, £300-400. That's a lot more useful. Trending things, image analysis. Yeah, it's great. Actually, it's not that good so far. The general standard of DTA research, I would say, is lousy. The technology is good, but the evaluation is poor. And it's mainly due to a lack of very classical biases that have been known for 40 years, and particularly matching the research question to the clinical situation in that pathway. That's, to me, one of the great sort of visions of looking at this whole body. And I'd like to pay my respect. We did bite off more than we could chew. It did nearly kill us. We did probably 200% more work than was originally planned for in that grant we wrote in Quebec. But actually looking back, I think it was a very useful, huge team of work. And I would strongly advise, because I haven't gone into any details of the reviews, that when you get a moment, go to the Cochrane Library, look at the special collection, and read maybe a couple of abstracts of the topics that interest you. I should close there. Thank you.
So we are running about 30 minutes late on our program, so we have time for one quick question for Hal, even though I'd like to hear him talk all day. His dramatic Welsh voice. Okay, we'll move on.
Okay, that's fine. Okay, thank you.
Perfect.